right, thanks a lot, Jeff. And I'd also like to thank Tasha and Jerry and this Children's Cancer Foundation staff for pulling this together. It really is nice to have a regional meeting and to talk with each other and have an opportunity to exchange ideas. I'd also like to thank the Children's Cancer Foundation for supporting a lot of research that has occurred at Children's National over the years and also the other centers in the region. As Jeff said, I think it's a very important initiative to develop local investigators. So when we were thinking about planning this meeting, we wanted to highlight different areas that have received funding from the Children's Cancer Foundation. And the areas that we decided to focus on are sarcomas, neuro-oncology, and immunotherapy. And we're going to start with the sarcoma session. And what I'd like to do is just give a brief overview of pediatric sarcomas and talk about where we stand in terms of treatment and outcomes and recent clinical trials. And then that will pave the way for some of the new science that we're going to hear about. So by way of introduction, childhood and adolescent sarcomas account for about 12% of cancers in children and adolescents up to 19 years old. And the way that I like to conceptualize it's pretty simple. You can divide the sarcomas into two broad groups, the soft tissue sarcomas, which comprise about 60% of pediatric sarcomas, and bone sarcomas, which are about 40%. And then the bone sarcomas can be further divided into the two main bone tumors that we see. One is osteosarcoma, and the other is Ewing sarcoma. And the soft tissue sarcomas can be divided into the rhabdomyosarcomas, and the other group, which has a very creative name, which is the non-rhabdomyosarcoma soft tissue sarcomas. So this is a graph that I made with Airang Kim and Holly Meany for a chapter that we recently wrote for a book that Bob Henshaw, who's our orthopedic oncologist, is editing. So that should be coming out soon. But this is a compilation of SEER data. This is the incidence rates for different sarcomas up to age 19. And there's a lot of information in this picture, so I'll walk you through it. So the blue bars are the annual age-adjusted incidence per million individuals of all sarcomas. So if you look at the blue, let me get my pointer. Very high-tech at Giant. That's really good. So the blue, so the blue are all the sarcomas, and you can see that interestingly, there's a peak of sarcomas in early infancy in children less than 1 year of age, and then the incidence of sarcomas goes down during the school, early childhood, preschool, and the school-age years, and then it goes up again during adolescence. So sarcomas are a disease of adolescents and young adults. And then this graph also breaks the sarcomas down into the different types of sarcomas. The red bar is rhabdomyosarcoma, and you can see that we do see some rhabdomyosarcoma in infants. Most of the rhabdomyosarcomas, the highest incidence is in the preschool kids, so age 1 to 4. And then the incidence of rhabdomyosarcoma goes down during school age and adolescence, but we still see rhabdomyosarcoma in that age group. Then if we go to the creatively named tumor, the non-rhabdo soft tissue sarcomas, there's a peak in early infancy, and this is largely due to the tumor called infantile fibrosarcoma. And then you don't see much non-rhabdo soft tissue sarcoma in preschool kids or school-age kids, but you begin to see it in the second decade of life. And then moving to the bone tumors, osteosarcoma is the purple bar. We don't see osteosarcoma in infants or preschool kids. We see a little bit in school-age kids, but the incidence goes up during adolescence. And Ewing sarcoma follows a similar pattern to osteosarcoma, but sometimes we do see some preschool kids with Ewing sarcoma. And at Children's National, we follow a couple of patients like 2 and 3 years old with Ewing sarcoma. It's unusual, but we do see it. So how about outcomes? So where do we stand in terms of progress that has been made? And this is, I'm going to show you a series of graphs from a paper that was published by Malcolm Smith and colleagues at CTEP. And this is based on SEER data, so the Surveillance Epidemiology and End Result program at the NIH. So just to orient you to these graphs, this is a graph of the 5-year survival rate for children and teenagers with osteosarcoma. The yellow bar, the blue bar are children less than 15 years old, and the yellow bar denotes teenagers from the age of 15 to 19. So I'll just walk you through some of the trends. So for osteosarcoma, in 1975 to 1978, the 5-year survival rate was between 40 and 55%, depending on the age group. The outcomes then were worse for the children less than 15 years of age. And then there was an improvement in outcome, and between 1975 and 1987, there was an improvement for both age groups. But one thing that you could see from this graph is that there really hasn't been any improvement in outcomes since 1987. So there really, in osteosarcoma, unfortunately, there has been a plateau in progress since 1987, and that holds true for both of the age groups. Now, the improvement in outcome between 1975, like steadily going up to 1987, was due to the recognition that chemotherapy is effective for osteosarcoma. And this was a landmark paper published by Mike Link in 1986 in the New England Journal of Medicine. And this was the result of a study called the Multi-Institutional Osteosarcoma Study, MIOS. And it still boggles my mind that in 1986, it still wasn't accepted that chemotherapy should be an accepted therapy for osteosarcoma. There were large institutions that doubted or were skeptical about the role of chemotherapy. And to me, 1986 doesn't seem like so long ago. Like, Tears for Fears was around, and AHA and other groups like that. And at that time, it still wasn't accepted that chemotherapy is helpful. So this study established, it was a randomized study, and you could see on the survival curve that the patients who received chemotherapy did much better than the patients who did not. And after that, chemotherapy became standard. So after that, though, so that was great, and everyone started using chemotherapy. But after that, not much has happened. And I'll just show you the most recent study that was done by the Children's Oncology Group. So after the Link study, the standard chemotherapy that evolved is what we call MAP chemotherapy. It's methotrexate, doxorubicin, and cisplatin, MAP. And the standard approach is to give neoadjuvant therapy, give 10 weeks of chemotherapy before surgical resection, and then after surgery, you give more chemotherapy. So this is a diagram of how the treatment was given on this study. So here's the 10 weeks of that chemotherapy and then surgery. And then once surgery is done, the tumor can be examined under the microscope, and the percent of necrosis, the percent of death in the tumor cells can be determined, and that's been shown to be a valuable prognostic marker for osteosarcoma. So the patients with a good response, those are patients with a high necrosis rate in their tumors, they went into one treatment arm, and the patients with a poor response went into another treatment arm. The patients with the good response were randomized to get the standard chemotherapy, that methotrexate, doxorubicin, and cisplatin, or the methotrexate or the chemotherapy with interferon, which is an immunostimulator to help to boost the immune system to fight the osteosarcoma cells. So the results of that were that there was no benefit to the experimental arm. The interferon was not helpful, So for patients with a good histologic response, MAP therapy remains the standard treatment. Now for the patients with a poor histologic response, the randomization was between MAP and MAP with 2 other chemotherapy drugs, ifosfamide and etoposide. And a lot of people were optimistic that adding these 2 other drugs would be helpful, with the theory being that if the response wasn't that good to the 3 chemotherapy drugs, adding the 2 additional drugs would make it better. And unfortunately, the answer was that there was no benefit to the MAP-IE chemotherapy. So sort of counterintuitive. In oncology, we like to think more is better, but that isn't necessarily the case. And this arm, the MAP-IE, was associated with more toxicity, but not a benefit in terms of event-free survival or overall survival. Now, that's all for localized disease. For metastatic disease, one of the recent COG studies evaluated a bisphosphonate, which has an effect on bone resorption and bone metabolism, and was shown in preclinical studies to have an anti-tumor effect against osteosarcoma. So this zoledronic acid was added to the standard types of chemotherapy, methotrexate, doxorubicin, cisplatin, ifosfamide, etoposide. And the answer at the end of the study was that the 2-year event-free survival was only 32%. So really there wasn't any improvement for metastatic disease in the patients who got zoledronic acid. So other strategies were tried: inhaled GM-CSF, osteosarcomas express HER2, which is known mostly for its expression in breast cancer. No benefit for Herceptin. The most recent study looked at a drug called eribulin, which targets microtubules, and that showed promise in preclinical models of osteosarcoma, but unfortunately there were no responses seen in a phase 2 study of children with osteosarcoma. So really, we just haven't made a lot of progress since 1987. So what's going on now? What are the new offerings? Well, there's a study looking at dinutuximab, which is an anti-GD2 antibody. This drug is best known for its role in treating neuroblastoma, and several years ago it was noted that GD2, the ganglioside, is also expressed on osteosarcoma cells. So the idea was to have a study looking at dinutuximab that's enrolling now in the Children's Oncology Group. There's also a study of denosumab, which is a rank ligand inhibitor expressed in osteoclasts. So that is a phase 2 study open for recurrent osteosarcoma. And the newest one is difficult to pronounce. It's another antibody drug conjugate called glembatumumab, and that targets a protein called GBNMP that has been found on the surface of osteosarcoma cells. And that study is open as well. So we don't know the results yet of these studies. So moving on to Ewing sarcoma, where do we stand? So this is the same bar diagram, bar graph looking at 5-year survival rates over time. And if you go back to the first group, 1975 to 1978, and compare the outcomes to what was achieved in the 1990s, 1991 to 1994, you can see that a lot of progress was made between the 1970s and the 1990s. But just like osteosarcoma, unfortunately, since 1991, there really hasn't been much progress made. And the other thing that you can see here is that the younger kids with Ewing sarcoma less than 15 years of age do better than the older kids, so between 15 and 19 years of age. So, but again, we have the same problem where not much progress has been made since the early 1990s. So what happened? What caused the rise from the 1970s and 1980s to the 1990s? And remember, for osteosarcoma, the increase was the recognition that chemotherapy is helpful. For Ewing sarcoma, there was a landmark study called the INT0091 study that was published by Holcomb Greer in the New England Journal of Medicine, where patients were randomized to receive chemotherapy with vincristine, dactinomycin, cyclophosphamide, and doxorubicin, or those agents with ifosfamide and etoposide. And you can see that there was a highly significant difference in event-free survival between those groups in favor of the group that got ifosfamide and etoposide. So that was for localized disease. And this is the Kaplan-Meier curve that shows that difference. So this is the group that got ifosfamide and etoposide. This is the group that got the chemotherapy without those drugs. So we knew that IE is beneficial for Ewing sarcoma. Now, unfortunately, the story was different for patients with metastatic disease. And these are the two arms for patients with metastatic disease, and they're superimposable. So the ifosfamide and etoposide had no benefit for metastatic disease. So then the next idea in the children's oncology group was to say, well, if we normally give chemotherapy every 3 weeks, would there be a benefit of giving chemotherapy every 2 weeks with growth factor support, like GCSF? And maybe if you can give the chemotherapy in a more dose-intensive fashion, the results would be better because there would be less time that the patient has a break between chemotherapy cycles. And I have to admit, when this study came out, I was very skeptical about it. And I said, oh, is that really the best the Ewing Sarcoma Committee has to offer? But it turned out that there was some benefit. I would say that there's a modest benefit to giving the chemotherapy every 2 weeks instead of every 3 weeks. And that's shown on the survival curves here. This is event-free survival, and this is overall survival. And the blue line are the patients who got chemotherapy every 2 weeks, and the yellow line are patients who got chemotherapy every 3 weeks. So now giving the so-called dose-compressed or interval-compressed chemotherapy has become the standard treatment backbone for Ewing sarcoma, although it's certainly not a home run. So for metastatic disease, the COG participated in a study called the Euro-Ewing study. And the idea here was to take patients with metastatic disease to the lungs, which is the most common site of metastatic disease, and randomize patients to get either lung radiation at the end of chemotherapy or high-dose therapy with stem cell rescue using busulfan and melphalan as a preparative regimen. And this is still a debate in the field. Is high-dose therapy with stem cell rescue beneficial for Ewing sarcoma? And the results haven't been published yet, but I've heard that there isn't a difference in outcome. So it will come out this week, I guess, and Jeff tells me. I bet this isn't going to lay the question to rest, because there are some methodologic and design issues with this study. But I think it argues against the role of high-dose therapy with stem cell rescue. And a current study in the COG adds a biologic agent to the chemotherapy, this drug, ganitumab, which is a drug against the insulin-like growth factor 1 receptor. And preclinical models and phase 1 and phase 2 studies have shown activity in a portion of Ewing sarcomas with this class of agents. So it'll be interesting to see whether the addition of a biologic agent provides benefit on top of the usual chemotherapy backbone. So some of the new offerings in Ewing sarcoma are targeted therapy against EWS-Fly, and we'll hear a lot more about that from Jeff. PARP inhibitors have shown some promise in preclinical studies. And that drug, eribulin, that I told you about with osteosarcoma, has also shown promise in preclinical models of Ewing sarcoma. So there's a phase 2 study that's ongoing now, and we don't know the results yet. So moving to rhabdomyosarcoma, here's our curve again, and you're going to see a recurring theme. So we did make progress from 1975 to, in this case, 1979. But really, if you look at the 5-year survival since 1979, it's been really flat. So same theme, haven't made a lot of progress lately. Reminds me of that Janet Jackson song, "What have you done for me lately?" But, so the answer is nothing for here. So the COG approach to rhabdomyosarcoma has been to study, do a series of phase 2 window studies. So you have a patient with metastatic disease, they have the highest risk of disease recurrence and death. So they study new agents in a window therapy to get a readout of whether the tumor responds. And if the tumor responds, then the agents are incorporated into the backbone of the chemotherapy regimen. So this is a series of windows that the intergroup rhabdomyosarcoma study group studied, and the COG. And you could see here's ifosfamide doxorubicin, ifosfamide etoposide, topotecan, topocyclo, irinotecan. The latest one that isn't on this graph, on this chart, is irinotecan vincristine. And the tumors respond, so the response rates are typically over 50%. The highest response rate was with vincristine irinotecan, where it was about a 70% response rate. But the problem is, even though the tumors respond, when you look at how the overall survival is, it's not much different. This orange curve is the standard regimen with vincristine, dactinomycin, cyclophosphamide, and all the window therapies aren't much different. So all these drugs show activity, but then when you add it to the backbone of VAC chemotherapy, it really hasn't budged the survival curve. So the latest COG study for metastatic rhabdomyosarcoma was what I call the kitchen sink study. So this pulled out all the stops. They gave dose-intensive chemotherapy, like with Ewing sarcoma, every 2 weeks instead of every 3 weeks. They added vincristine and irinotecan based on the activity in the phase 2 studies. They had doxorubicin in there. They had ifosfamide and etoposide. They had the standard VAC, so they had a little bit of everything. And they thought that maybe if they do everything and throw the book at the tumor, then the response rate will be better. And the preliminary results were interesting. There was some promise that the failure-free survival, note the timeline here at 1 year, was better than the historical controls, but this hasn't held up. And now the feeling is that this very intensive regimen isn't any better than VAC chemotherapy for the majority of patients. So there was a study for relapsed rhabdomyosarcoma comparing bevacizumab, the anti-VEGF drug, with temsirolimus, an mTOR inhibitor, that found that the temsirolimus was superior. And based on that, there's now the current study for intermediate risk rhabdomyosarcoma is a randomization of VAC, vincristine irinotecan backbone, with or without temsirolimus. So that is still open. We don't know the results yet. And just for completeness sake, I mentioned non-rhabdo soft tissue sarcomas. The outcomes, just like with the other sarcomas, the outcomes for patients with localized and resected disease are better, much better than patients who have metastatic disease. And the new approach for this tumor is to add pazopanib, which is a multi-tyrosine kinase inhibitor, with or without chemotherapy, depending on the type of non-rhabdo soft tissue sarcoma. Some of them, like synovial sarcoma, are more chemosensitive than others. So just to summarize, some of the themes that we discussed are that survival for pediatric sarcomas has improved from 1975 to the late 1980s or early 1990s, depending on the tumor, but survival really has been very steady since then, which has been very frustrating because different therapies and different approaches have been tried. Survival is particularly poor for patients with metastatic disease. And in general, survival has been worse for adolescents and young adults than for younger children. And the real take-home message that I get from this is that new approaches are needed. So a lot of the approaches that have been tried have been adding different traditional chemotherapy drugs, traditional cytotoxic drugs to the backbone, the standard backbone of chemotherapy. And it seems like we've got as much mileage as we're going to get with that approach. We probably, we peaked in the early 1980s, and now we have to think differently. We have to think outside the box. And we're going to hear about some of those novel approaches later in the symposium. So again, I'd like to thank the Children's Cancer Foundation and Jeff for organizing the meeting. And hopefully we'll have time for 1 or 2 questions, and then we'll move on. Thank you. I could. Let's see. Yeah, there's one, I noticed that. Yeah, I looked at that for a while. It seems like this number, it seems to be an outlier. It's really surprising to me, and I couldn't think of a good reason. Jeff, do you have an idea?
Yeah, so part of it has to do with classification, and at that time, there was some of the bone Ewings were not necessarily going to be counted in Ewings. It was sort of like a classification thing, and so it's a guess based on that sort of historical point that these may be representing non-bony, a lot of, not all, but a lot of non-bony, so soft tissue Ewings that were completely resected. And some of those did fairly well. And also, in 75, we had the really good Ewing Sarcoma study was starting to use 3-drug therapy for the first time. And so IESS1, or rather IESS2, and so it's possible those patients got that combination of vincristine, doxorubicin, and cytoxan. And the combination of those things may be why you saw that. And I think the reason it dropped is you start including more patients in the second cohort, is what I think is what's going to happen. But I have to go back and look at it, but I think that's right.
All right. Any other questions?